Buenos días. Bienvenidos al segundo día del Congreso Internacional de nuestro Instituto sobre Investigación en Obesidad. Como lo mencioné ayer, realmente estamos muy entusiasmados y emocionados con esta iniciativa. Y el día de hoy, ese segundo día, tenemos la oportunidad de escuchar a conferencistas magistrales, pero también, como mencioné el día de hoy, vamos a tener la oportunidad de continuar viendo los proyectos que se están llevando a cabo dentro del instituto a través de la modalidad de presentaciones cortas y, muy importante, nuestra sesión de carteles a las cuales los invitamos cordialmente. Ahí tendrán oportunidad no solo de ver un poquito más de detalle los proyectos que estamos desarrollando, sino interactuar con los investigadores que forman parte del mismo. Como siempre, sus comentarios, preguntas y retroalimentación es bienvenida. Sin mayor preámbulo, le pido al doctor Gerardo García que sea tan amable de dar inicio a este segundo día de conferencias presentando a nuestro primer keynote speaker del día de hoy. Gerardo.
Gracias, Marco. Buenos días a todos. Un gusto estar aquí en ese segundo día. Esperemos sea tan exitoso como el día de ayer. Y hoy para mí es un honor, por supuesto, y un placer presentar al profesor Douglas Mann. Primera vez que históricamente presentaremos en español al profesor. El profesor, tomaré un minutito solamente para comentarles algunas situaciones o algunas background del profesor. El profesor Mann obtuvo su grado médico de la Universidad de Temple School en Filadelfia y complementó su entrenamiento clínico en cardiología en la Universidad de California y posteriormente en Massachusetts General Hospital en Boston. El profesor Mann tiene como principales líneas de investigación el estudio de los mecanismos celulares y moleculares que son bases de la progresión de la falla cardíaca. Él sirvió como jefe del Departamento de Cardiología en Baylor College of Medicine y hace 30 años tuvo la oportunidad de ser mentor de ahora el doctor Guillermo Torre, rector de TechSalud y vicepresidente de investigación del Tecnológico de Monterrey. Dicho sea de paso, una invitación. Es tan tarde, en esta misma aula tendremos una sesión de gigantes de la medicina en donde el doctor Torre y el doctor Mann conversarán de esos tiempos seguramente. Posteriormente, en 2009, se movió como jefe del Departamento de Cardiología a Washington University. El doctor Mann es profesor del Departamento de Biología y Fisiología Celular de la Universidad de Washington y ha publicado más de 300 trabajos. Es miembro editorial de comités de revistas como Circulation, The Journal of American College of Cardiology, JACC Heart Failure, y más recientemente es el editor en jefe fundador del JACC Basic and Translational Science. Entre otros honores que ha recibido el profesor Mann es el Michael DeBecke Award for Excellence in Research, the Alfred Sofer Award for Editorial Excellence, the Distinguished Mentor Award for the American College of Cardiology, and the Lifetime Achievement Award for the Heart Failure Society of America. Por ello, el profesor, estamos muy honrados de que el profesor nos acompañe este día con su lectura La recuperación del corazón con falla cardíaca. Thank you very much.
So my Spanish is a little rusty, but I think that was an overly gracious introduction, but thank you nonetheless. I want to begin by thanking Dr. Torre and TechSalud for inviting me here today. I've learned so much about the excellence in research and the innovative approaches that are being taken here to combat obesity. Today, I'd like to switch gears a little bit and talk about heart failure. I'll explain why that's important to people who are interested in obesity in the next few slides. But first, I had to dust this one off. This is around 1996. We had no money, a lot of ideas. We didn't sleep a lot, but at the time we started doing inflammation and heart failure, there were 4 articles in the entire world, and Over the ensuing year that Guillermo was in the lab, we published a series of papers. Our group was the first to show that non-inflammatory cells, such as cardiac myocytes, could elaborate cardiac cytokines. There was a paper that I'd asked Guillermo to do to try to identify receptors, TNF receptors on cardiac myocytes. And we had a hard time doing it in primary myocyte isolations. And then Guillermo kind of revolutionized the lab by bringing in human heart failure tissue, and it just sort of revolutionized our approach. The paper that I think was probably the most compelling was that Guillermo took the observations that his colleague Samir had done and showed that the failing human heart expressed TNF, whereas the non-failing heart didn't. And then the mother of all papers was the analysis of the solved, which continues to get multiple citations per year. One of the greatest things about being a mentor is to watch your mentees and trainees go well beyond anything that you could have ever taught them. And Guillermo, you're no exception, so thank you. Okay, why talk about heart failure at an international conference on obesity? Well, the honest answer is I only know one thing, and that's heart failure. But more relevant to the conference here is that obesity is a major cause of developing heart failure, both in men and women. This is a study from Kenchaya, and what they showed in about 1,000 individuals from a longitudinal, the Framingham study, was that the incidence of developing heart failure was about twofold in women and about 1.9-fold in men if they were obese and overweight. Now, at that time, we didn't know much about heart failure, preserved ejection fraction. I would speculate that the majority of these people probably had a metabolic phenotype and developed heart failure with a preserved ejection fraction. So obesity and the treatment of obesity, as it turns out, is very important for the recovery of heart failure, which is the topic today. So today we know a lot about this process known as cardiac remodeling. We know that when the heart becomes injured, it dilates, and then it goes a process known as remodeling, where the walls get thinner and the cavity dilates. Work done by Dr. Torrey when he was in Houston and many others have shown that medical and device therapies for treating heart failure are remarkable, that we prolong lives and make people better. There are a number of different kinds of reverse remodeling that occur. You can get complete restoration of left ventricular structure and function. Unfortunately, this is far too rare. More commonly, we develop what I call partial recovery of heart failure. The ejection fraction goes from less than 40 to somewhere between 40 to 50. And then there are a group of people, unfortunately, that really don't do well on any medical or device therapies and need to go on to transplants and LVADs, left ventricular device support. So my talk today is really going to focus in on the upper panel, the full recovery and then the partial recovery, and just relay some new information we have about what the biology of this is and what it really portends for medical therapy going forward. So when we first started to try to study this, it was clear that the nomenclature for the field was incredibly messy. There were terms such as heart failure improved EF, preserved EF, borderline EF, recovered EF, mid-range EF. The definition was completely opaque. Some people thought the EF should increase 5%, some said 10%. It was unclear whether it had to improve more than 40%. The clinical course was completely unclear. And more importantly, for people like me who study biology, we didn't really understand what the biological substrate was. So I was fortunate enough to work with a group of really talented and energetic people who were interested in this, and we published a position paper in 2020 to try to just put a stake in the ground about what heart failure with recovered EF was. And since then, some of the ideas that we put forward have been validated and put into to practice guidelines, and I'll just sort of share this journey with you. So we came down on the writing committee that we should call it heart failure with recovered EF. Turns out that the practice guidelines didn't hold on to that. We felt it was important that the ejection fraction increase more than 10%, and that also was not necessarily held on to by the practice guidelines, but I think it's incredibly important. And then we all, I think everyone agrees that the ejection fraction needs to at least get above 40%. So these are the things that we came forward in our consensus statement. And before I begin into sort of going into all the different studies, it's important to really tell you what ejection fraction is, and I hope Dr. Torre agrees with me. When we measure ejection fraction, it's a surrogate for how big the volume is. If you look at the equation, it's the end diastolic volume minus the end systolic volume divided by the end diastolic volume. So as the ejection fraction goes down, it's because the heart's getting bigger. Part of that, yes, is contractility, but the bigger part, I think, is this process known remodeling. So when we talk about ejection fractions improving, it's largely because the hearts are getting smaller. So I kind of, when I see an ejection fraction, if it's low, I go big heart. If it's normal, I go small heart. But it's not necessarily what they taught you in medical school. So what about the epidemiology of heart failure with a recovered EF? This is sort of where we started. As it turns out, this is remarkably helpful to go back and look at the examples of nature in terms of what actually does happen to heart failure with a recovered EF. So there was a wonderful article by Holloway and Ken Margulies that broke down the recovery of ejection fraction into sort of three major groups, what we call abnormal energetics. These are like a tachycardia-induced cardiomyopathy or a Takotsubo-type cardiomyopathy. Toxic insults, which when I was a house staff was mainly cocaine. Today it's mainly chemotherapy. And we know that if we give certain chemotherapeutic agents, the ejection fraction will drop, and if we stop them, it'll improve. And then what really my lab, and I think Dr. Torre's lab has studied really for 30 years, is the role of inflammation. When inflammation occurs, you get depression of LV function. When inflammation resolves, then you get recovery of LV function. So a number of years ago, I collaborated with Mike Gevirtz, and we went through the entire world's literature at that time, and that was now over 10 years ago. But what we did was to try to look at all the papers that had included improvement of ejection fraction and what the ejection fraction actually was at the end. And this was a remarkably insightful analysis that informed our thinking. So shown in the back are the blue bars. These are the percentage of people in each category that improve their ejection fraction by more than 10%. And as you can see, most people, at least 50 to sometimes 100%, will at least improve the ejection fraction by 10%. More striking, I think, is the number of people who normalize their ejection fraction, who get it back to 50%. And if you see that the energetic group, almost all those people come back to 50%, and if you go all the way to the right and you look at the inflammatory causes, only about half of those people will normalize their ejection fractions. So the amount of recovery you get depends on the kind of insult or injury that occurs with myocardial injury. So as it turns out, all the drugs and devices that we use in heart failure today work in part by allowing the heart to get smaller. This is a complex graph. I'll just tell you that what it shows. ACE inhibitors, so-called ARNIs, spironolactone, mineralocorticoid receptor antagonists, beta blockers, cardiac resynchronization therapy, and LVADs all work by allowing the heart to get smaller. Even SGLT2 inhibitors, although the data are a little conflicting, appear to work in part by allowing the heart to get smaller. So this concept that when the heart heals, it gets smaller and people do better was fundamental to our thinking in heart failure. And for a number of years, we thought that that was sufficient. So the first take-home message, I think, is that once you remove the inciting event, the heart gets better. And for a number of years, what I refer to as the LVAD mafia, the people who were doing left ventricular assist devices, who would put these complex devices and pull them out, they were the only ones that thought they could do this. As it turns out, nature does this very well. So the heart gets better if you take away the inciting event. And when we give medicines, we're taking away the inciting event. The other take-home message is that although recovery of function occurs frequently, normalization of the ventricle varies according to the nature of the insult. And this, as it turns out, is incredibly important. So what about the durability? So when we became interested in this, there were early reports that the stability of recovery was not what we thought it should be. And this kind of violated what we thought as clinicians, because if you're on the right medicines and you stay on those medicines, you should stay better forever. And that really wasn't what was happening. So there was a fellow at Washington University, Ashish Rastogi, and he needed a cardiology fellowship. So I said, I have a really great project. We'd had, when I first went to WashU, we set up a database. And I was agnostic about ejection fraction. I said, just put all the patients in the database regardless of ejection fraction, and then we're going to collect serum and DNA and do longitudinal follow-up. Well, back in around 2015 and 16, there was a group of people in the middle, the so-called heart failure mid-range EF, between 40 to 50. We didn't know who they were. We knew what heart failure reduced EF was, less than 40, and preserved EF, greater than 50. We had a lot of epidemiologic data, but the group of people in the mid-range, we had no idea who they were or what they were. So I asked Ashish to go back into the database and determine what the ejection fraction was before they were enrolled in the registry. So on the bottom, you can see that most of the patients were heart failure with a reduced EF that had gotten better. Okay, there were about 123 of those that had gotten to the mid-range. There were only a very small number that had preserved, that had deteriorated, lost their EF, and that's consistent with the clinical literature. And there were very few people that had always had mid-range EF as far back as we could tell. And then we did standard things. So the first thing we did was just to compare Kaplan-Meier curves. This just shows death, transplant, or heart failure hospitalization. And in panel A, you can see the upper line of the improved people. And in the lower line are the people with reduced EF. And this really should come as no surprise because the upper line represents people who responded to medical therapy. So if you get better on medical therapy, you stay alive longer and stay out of the hospital longer. Panel B is more informative, and this is where things became really interesting for us. So if you look at the upper panel there, you can see that the heart failure mid-range EF and heart failure preserved EF, this is again a classic form of heart failure, they had the same shape of Kaplan-Meier curve. And this means that these people, despite the fact that they responded to medical therapy, were still coming into the hospital very frequently. And again, this violated everything that we knew about heart failure biology. So we went on then to use a proteomic approach to this, and some of the projects that I saw here today, I think, would really benefit from this broad-based proteomic approach. What we did was to take the three groups of people that I outlined, reduced EF, preserved EF, and mid-range. We grouped them and then performed a proteomic signature on them using the SomaLogic platform. Now, this is an older paper. We only had it measures 1,000 proteins simultaneously. And what it does is it'll take a so-called aptamer, which I'll explain in the next slide, that binds to proteins, and so you can identify 1,000 proteins in one small sample of blood. And then we performed a bioinformatic analysis. So this just shows how the technique works. There's a DNA aptamer that's specifically designed to bind to a specific protein. That then gets biotinylated so you can identify it. And you can go through a series of steps to capture the protein and then separate the aptamer from the protein and then bind that aptamer onto a chip. And the chip will know what the aptamer was. So the unfortunate part about SomaLogic, it doesn't give you a quantitative amount, but it just compares two proteins. So in the graphs that I'm going to show you in the next slide, if there's a lot of gray, that means the protein levels are exactly the same. If there are differences in color, it means that they're different. So if it's red, there's more protein in one group. If it's blue, there's less protein. And so on the next slide, you'll see the differences. So when we compared heart failure with a reduced ejection fraction to heart failure with preserved, you can see there's a lot of red and blue. And we know that there are really two different flavors of heart failure. And so that's not surprising. More surprising was when we looked at the heart failure reduced EF compared to the mid-range group. And again, remember, most of the mid-range group had come from the reduced EF. You can see that there's even more red and even more blue. And this implies that the recovered EF is actually a unique biologic state. And I think that conclusion and observation is correct. And then if you compare the mid-range EF to the preserved EF, you see there's not a lot of blue and red, there's a lot of gray. And that means that they're very similar at the protein level, And if you remember back on the Kaplan-Meier curves I showed you, they're very similar as well. So there's something about when the heart gets better, it goes to a new steady state, which we'll talk about a little later on. And I think it's a unique group of patients. They have unique biology. So if you just do what they call PCA analysis, that's where you can take all the variability and group it into a very simple way of looking at it. You can see that the reduced EF is off to the left, the preserved EF is off to the right. And that mid-range group is separate, but very close to the preserved EF. And remember, their outcomes are similar. So the proteomic signatures do predict the outcomes. And then if we further slice and dice the patients, the people who were in that mid-range group who had clearly improved their ejection fraction, they're distinct, but the ones in the mid-range that had just sort of never improved their ejection fraction, they're somewhere in between. So this doesn't tell you which proteins are driving it, but it does give you, I think, some sense that the biology is vastly different in heart failure after they're on medical therapy. So what about the durability of a complete recovery? Remember I said that's the minority of patients. We normally don't see people who recover completely. This is a really nice study done by Bazaray and Jim Fang. And what they did was to go into the Penn database and look at people who recovered their EF, people who had a reduced EF, and then people who had reduced EF, preserved EF, and then recovered EF. And you can see that the worst ones in terms of probability of death and hospitalization are the reduced EF, and that's not a surprise. The recovered EF do the best. Again, responding to medical therapy is a good thing. But if you go look at panel B and just look at hospitalization, again, the hospitalization curves are identical. So these are people who, on the best medical therapy that we have, who I think even Dr. Torre, who's a skeptic sometimes, would agree that they're better, right? Their ejection fraction's completely normal. They're still coming into the hospital with heart failure hospitalizations. So what's up with that? So it made no sense to me that on the best medical therapy we have, these people are still coming into the hospital. And when I was in medical school, we would blame it on the patients, say they're non-compliant. These are not non-compliant people. Even more compelling was a study by an Italian group, Merlo. They had a group of people who have dilated cardiomyopathy. So these are people that couldn't have an ischemic event to drop their EF or send them to the hospital. And they used a very vigorous definition of recovery. Only 15% of their 400 patients shown in the red bar were patients who had recovered. And then when they followed them out over time, they noticed that, again, about half of these well-treated, carefully followed patients were redeveloping heart failure and dying. So again, this concept that even though the heart gets better, people still have heart failure didn't really quite fit with what I thought I knew about heart failure. So again, the observation that heart failure recurred in patients whose structure and function is completely normal was difficult to reconcile with anything that I thought I knew about the biology of heart failure, because if the heart got smaller, it had to be better. It couldn't fail again. So part of the problem was that I had been raised in the J. Cone era of heart failure, and at that time, remodeling was the holy grail. If you could get the heart to reverse remodel, you were a good doctor. So shown here is a consensus statement. Although remodeling is generally accepted, is a determinant of the clinical course of heart failure, slowing or reverse remodeling has not until recently been the recognized goal of therapy. And for me and many people who trained in that era, this was the goal. The other problem was that leading textbooks in medicine said that reverse remodeling was synonymous with resolution of heart failure. The problem was I wrote every single one of these chapters in these textbooks, and so take-home message number 3 is you have to avoid drinking too much of your own Kool-Aid because you get confused and hungover, right? So sometimes you have to kind of rethink the way you approach things, and clearly reverse remodeling was the beginning. It was necessary, but not sufficient. So a number of years ago, we were at a Gordon conference, and I had a glass of wine, and I was talking to Dan Burkhoff, and we were surrounded by people, again, what I refer to as the LVAD Mafia. It was a Gordon conference on circulatory assist devices. And I said, Dan, do you really think recovery ever exists? And he goes, hell no. So we went out into the woods the next day and just sort of talked about it and came up with a really simple model system So shown on the left is heart failure, and I kind of think about heart failure as the myocyte, shown by C, the myocardium, extracellular matrix, shown by M, and the LV geometry shown is LV. And we said there are probably two groups of ventricles. There's one group that remodels but comes back in the hospital, and then there's a smaller group that remodels and never needs to see a doctor again. So we asked the question, is there something intrinsically different about the hearts of these people? And the answer again was yes, and it had been staring us in the face for a lot of years. It just didn't fit into the paradigm. So we were struggling with what to call these, and I wanted to put a stake in the ground for what myocardial recovery was, because I felt the LVAD people were just claiming victory. They would pull the LVAD out, a patient would be free of heart failure for a week, and then they'd put the LVAD back in, and they were claiming that was recovery. So we said that the heart has to stay better forever, and you can't come back in the hospital. More importantly was this concept of remission. We didn't know what to call it at that time, but I said, well, if it's maybe a lot like cancer, maybe the heart failure is coming back. So we called this remission, and of the two different ideas, remission was the one that I think was more important in terms of understanding what we're dealing with. So what are the biological determinants of myocardial remission? As I said, there's a really good reason for this, and it was there all the time. We just didn't put it together. So again, when I think about heart failure, I think about the myocyte, I think about the myocardium, and I think about the geometry, because all three of these interact together as the heart dilates and as the heart gets smaller. And I'll walk you through everything in the next series of slides and show you it never really ever gets better. So I've termed this the slinky hypothesis. I don't know if slinkies were a big thing in Mexico, but when I was a kid, you had one of these spring devices, and if you stretched it a little bit, and it would come back completely to normal. If you had a tantrum, which I had not infrequently, and you stretched it too far, it would never come back completely to normal. And I think the heart's a lot like a slinky. It gets too dilated and too much end organ damage. It never really comes back completely to normal. And I'll just sort of give you some ideas. So this is a study that we did where we looked also at mice data, but in human data, and we had patients that had been supported by a left ventricular assist device. So we were able to get gene profiles in heart failure after they had recovered. All of them improved their ejection fraction. And we looked at the genes in the heart failure and then what we called the reverse remodeling genes, put them all together. And you can see here, and I'll have to use the pointer, but there's the non-failing group is shown in red. The dilated after LVAD is shown in green, somewhere in between. And the blue shows the dilated pre-LVAD. So again, this concept that the heart comes partially back, at least at the transcriptional profile level, was shown, I think, really nicely by this study and a number of other studies. So again, when I break down the myocyte biology, I think of various gene modules, and I don't want to get too technical, but I think about the matrix, how the matrix is linked into the sarcomeres. I think about the sarcomeres. I think about the mitochondria or energetics, and I think about EC coupling. And if you look on the right-hand panel, anything that's shown in the far right column is a gene that never gets better. So all of the gene modules, none of the genes get better except for the sarcomere genes, and there are only 2 of those genes, and that's just summarized here. So when you support a heart and the heart reverse remodels, the genetic profile, the transcriptional profile, doesn't really change that much. So that's the first clue that you have that reverse remodeling is not the end of the game. Really nice study by Armbedecker in Colorado. They took isolated myocytes and then they skinned them. They put them between these 2 tweezers so you can measure force generation, and they exposed the sarcomeres or the myocytes to increasing calcium. And you can see in the lower left plot, that's a force curve, more calcium, more force. And off to the right, if you look, you can see in a non-failing heart, it's about 15 millinewtons of force that the individual myocyte. A failing myocyte, before you put the LVAD in, has about maybe 3 or 4 millinewtons. So again, very reduced contractility. And then after it's supported and the heart gets better, you can see that the contractility actually improves. But it doesn't go back completely to normal. So now you have an abnormal transcriptional profile, a myocyte that's better but not normal, And as we go on with the story, you'll see that these cells are really halfway in between heart failure and halfway in between normal. These are electron micrographs, and you can just see the crisp sarcomere array in the left-hand panel. Before the LVAD goes in, there's complete loss of the sarcomere array, and the mitochondria look abnormal. They're swollen, and the cristae are blurred. And then after LVAD, the sarcomere array comes partially back. It's not as crisp, and the mitochondria come back, but again, not completely. This is also from the same paper. They went on and did very careful metabolomics on this, and they showed that in heart failure, there's the TCA, the cycle gets shut down. We know that. And then after heart failure, the TCA cycle is improved, but it doesn't go back completely to normal in that all those improvement in glycolysis, it gets shunted into lactate. It doesn't really ever get fed into the TCA cycle. So now you've got a myocyte that's structurally partially returned to normal. The energetics are abnormal, and the transcriptional profact is abnormal. So what about the myocardium? What happens to the matrix? The literature here is very confusing, and I know Dr. Torre has somewhat different findings in terms of the collagen matrix being completely resolved with the LVAD support. Part of it, I think, is that people didn't really understand the importance of medical therapy, and what Dan Burkhoff showed was that if you put people on ACE inhibitors and beta blockers, that you do get resorption of collagen the way that Dr. Torre had reported. So again, the matrix is probably not completely normal after LVAD support either. And then I think even more instructive is what happens to the shape of the heart. So normally we think about a dilated heart as being like a basketball, and there are two forms of stress. There is meridional wall stress and circumferential wall stress. When the heart gets smaller, the meridional wall stress will actually go down. So just by changing shape, the heart is unloaded. What's even more striking, though, is if you look at pressure volume curves, and these are done in human subjects, the heart failure ones are shown to the right. So when you get heart failure, the pressure volume curve shifts to the right. And with LVAD support, it shifts back to the left. But the really insightful part of this study was that if you look at the dimensions, they're getting smaller, but the R to H ratio, which is the radius to the wall thickness, which is a poor man's version of wall stress, never normalizes. Despite the fact that the pressure volume curves normalize, the heart can't normalize the stress. So now you have a myocyte that's abnormal, you have a matrix that's abnormal, and the heart can't normalize wall stress. It's just predictable that they're going to redevelop heart failure. So take-home message number 4, and it took 10 years of thinking about this to kind of put it together simply, but reverse remodeling, what we consider to be success clinically, is not a mirror image of the molecular and cellular pathways that become dysregulated. I showed you the evidence for that. Rather, reverse remodeling represents a multi-level process. It's at the myocyte, it's at the matrix, and it's in the geometry that all come back towards normal, and that's good enough to maintain pump function, at least in the short term. Importantly, many of the molecular changes that develop during remodeling remain dysregulated in the reverse remodeled heart, despite improvements in LV structure and function and what we as doctors would call victory. And I really think the simple way of thinking about this heart is really a mosaic. It's part heart failure, part normal, but it's a mosaic, but it's a completely different heart than it started out to be, and I showed you the proteomic evidence for that. So if you think about this and you try to put it together, I always try to take heart failure biology and put it in the context of broader biology. There's this concept of biological robustness. I was a physiology-trained physician, and we were used to homeostasis. It turns out biological systems don't necessarily operate on a homeostatic cycle, but there's this theory of robustness where what is postulated that when a system gets perturbed, it can go to the outer boundaries of its steady state, and if it doesn't go beyond those boundaries, it can come back completely to normal. So shown here, you can see that there's a steady state and it gets pushed outward, and if it goes back completely to normal, that's called homeostasis or robustness. On the other hand, if there's significant injury and the system gets pushed beyond its normal boundaries, it goes to a new steady state, just shown here is steady state 2. And I think what is really happening is that when we see recovery, true recovery, there's not a lot of injury to the heart, and the heart gets pushed out to the limits, but then comes back. The slinky doesn't get stretched much, but comes back completely to normal. But in really significant heart failure, where there's a lot of myocyte loss and disruption of the matrix, I think the heart goes to a new steady state. And that steady state, although it's good enough to maintain function, it's really not good enough to withstand the test of time. And that's why these people are coming back in with heart failure. There's a new biology that we don't understand well. So I know some people here are probably at this point going, why did Dr. Torre invite him here? This is not clinically relevant. I don't care about slinkies. I want to now show you the clinical data that actually support this. The greatest thing about doing science is every now and then you're right. And there was a study called the TREAD-HF study that came out in 2018. And when I read this, I said, well, at least if I die, I was right. So what they did in the TREAD-HF study was they took people who had completely recovered. These are, again, dilated heart failure. And they had a very rigorous definition of recovery. Small ventricle, ejection fraction greater than 10%, and NT-proBNP, which is a biomarker for heart failure, had to be normalized. They then assigned them one-to-one to a phased withdrawal of guideline-directed medical therapy, and then they followed the patients for 6 months. How they got this passed in IRB, I don't know, but when I read this, I said, this is pretty cool. So what they noticed was that within 6 months, the people that they took the medicines away from redeveloped heart failure. And in the discussion, they say these findings suggest that for many patients, improvement in cardiac function following treatment does not reflect full and sustained recovery, but rather reflects remission, which requires at least some treatment to be maintained. So this concept that the heart, even though it looks better, is actually remains abnormal, I think will provide new insights into how we can develop new therapies, and we're pursuing some new therapies along the autophagy line. Fortunately, the practice guidelines picked up on this. One of my other trainees, Dr. Beacom Boskert, was on the writing program for this, and they didn't like the idea of the heart ever getting recovered, so they decided to ignore our recommendations, and they used improved EF. And so their definition was a lot like our definition in that the ejection fraction had to be greater than 40%, and they emphasized the importance of following the ejection fraction, but they didn't really talk about the amount that it had to improve. Nonetheless, this was the first time that this entity had been recognized in practice guidelines. And shown here, they just clearly mark out heart failure. Improved EF is a separate category of heart failure with recovered EF, and they recommend, and this is the first time ever I think I've seen this, based on 50 patients, which is the entire TREAD-HF story, they recommend that people be kept on their medicines despite the fact that they feel good and their ventricles look completely normal. So I think this was, for us, I think, a victory. And then the question is, well, which medicines do you keep people on? And again, this just is where we are in the field right now. We don't really know. So there was a study called DELIVER. It was with dapagliflozin in people who, an SGLT2 inhibitor, greater than an ejection fraction, greater than 40%. And they were smart enough to, in their case report forms, capture whether the original EF had been less than 40 and at the time of enrollment was greater than 40. And what they were able to show, at least in panel A, was that the people who had so-called improved EF, they didn't really demonstrate that, but by some loose definition, that all those people did as well as the people with an ejection fraction greater than 40%. So this is the first evidence that that category of people, at least there's one medicine, an SGLT2 inhibitor, that works. And which drugs we should keep people on, we don't know. On the right-hand panel, I've shown a follow-on study from the TREAD-HF study where they just show you which drugs they were removing. And the one thing that happened very quickly, no matter what drugs they removed, is that the heart rate started to increase, and that's probably a sign of worsening heart failure. So we don't really know which drugs need people to be on, maybe SGLT2 for sure, forever. But could other drugs be withdrawn? Beta blockers have a lot of side effects. ARNIs have a lot of side effects. So stay tuned. I think other people are beginning to try to study this to figure out which drugs you can keep people on. And then the other important thing is that as we begin to study this group of people, it's very heterogeneous. We had done a study with another fellow, Luigi Adamo, that showed that when you recover, if your strain on echo is reduced, you're more likely to relapse and develop heart failure. Barry Greenberg did this much nicer, so I'm only going to show his data. What they did was to look at everyone who'd improved their ejection fraction greater than 50%, and they measured global longitudinal strain in all of those people. And you can see that there's people with very little strain and people with a lot of strain, which is a good thing. And so they looked at the median, which is about 12, and then they looked at outcomes. And you can see in the right-hand panel, the people who had good left ventricular strain, a lot of shortening, did much better than the people who didn't. So not everybody who has an improved ejection fraction will necessarily need medicines forever, and there are probably subsets of people that might even need more medical therapy. We also used a machine learning approach. We had a very talented resident, Andrew Perry, and what we did was to go back and look at 1,000 patients at Barnes-Jewish Hospital who had recovered their EF, and then just use machine learning to identify different clusters of people. The problem for this is, from a clinical standpoint, is it's not pure diabetics or pure hypertensives. But if you just look at the orange line, these were people who had a wide QRS that was not wide enough to put a CRT device in. But you can clearly see that there are phenotypes or phenogroups of recovered EF who drop their EF very quickly and who go on to die. So again, I think as we move forward in the field and identify different patient groups, we'll be able to figure out who needs to be on medicine and who doesn't. And then there's also the really interesting question of genetic variants. We know now that probably 60 to 70% of dilated cardiomyopathy has a genetic substrate. And a really nice study from the Spanish groups, they had 20 centers where they looked at people who had been genotyped, and they found that if you were gene positive for a known mutation, although you might reverse remodel and recover, there were subsets of people with desmosomal genes or nuclear envelope genes or sarcomeric genes who never reverse remodeled. Whereas, to my surprise, Titin, which is basically a sarcomeric gene, they actually recovered. And I've heard from colleagues in Europe, but they end up relapsing more. But so even the genetic substrate, I think, will tend to influence how long you stay in a state of remission. So again, this just goes back to the current American guidelines, where heart failure with an improved ejection fraction is recognized as an entity, and people are recommended to stay on medical therapy, whereas if it remains reduced, then there's a step therapy and additional medical therapies. But again, I think this is a step forward for recognizing this entity. So just to summarize this, I think patients with heart failure improved EF are very heterogeneous. And the clinical approach really needs to take into account the etiology of LV dysfunction. If it's an energetic hit, they probably will get better and never need to see a doctor. If, on the other hand, it's a profound myocarditis that drops the EF, they probably will develop the clinical syndrome of heart failure. We understand very little about which medications are actually required. We do know from the DELIVER trial that dapagliflozin, an SGLT2 inhibitor, improved outcomes in people who had that recovered EF. And then based on the results of the TREAD-HF study, and I have to emphasize this is 51 people. You know, heart failure, we're used to 6,000, 5,000 patient trials. This is 51 people. So the data are thin, but the current guidelines recommend continued therapy in all patients. And the importance of this is that when you relapse, oftentimes there's a leakage of troponin, so it's these recurrent myocardial injuries that end up pushing you to end-stage heart failure. So the idea of preventing people from relapsing and developing recurrent heart failure, as it turns out, is probably important. And we in the guideline recommending committee thought you could try to stop diuretics and then see how patients do, and if they don't do well, that's telling you something. But many people, once you stabilize them, they really become the need for diuretics goes away. And so that's the one drug we think you could probably stop and then follow people. So as it turns out, there's no original thoughts in medicine, and I don't want to claim that anything that I've showed you today is completely original. We've really always known about myocardial remission. We just didn't have the biological constructs to put it together. So when people get sick, at least with heart failure-reduced EF, there's a period when the ventricle dilates, they develop symptoms, and then they end up coming into the hospital. On good medical therapy, which as I showed you, the heart's reverse remodel, and people will stay stable 3, 5, 7 years. Some people stay stable forever. But ultimately, as I showed you, for a lot of people, they end up developing worsening heart failure despite all the best medical therapies we have today. And this, I think, represents an opportunity for innovation and new drug discovery. But this is a period where I think you reverse remodeling, you end up relapsing, and the hearts dilate again for all the reasons that I showed you. And I wanted to bring this back to the obesity symposium here. As I sat in the audience yesterday and I was thinking about it, many of the concepts that you're studying today do fit into this concept of robustness. And I think many of the concepts that I've talked about really apply to what you are all studying here. And so I think steady state 1, you could imagine, is obesity with metabolic dysregulation. And the new steady state 2 would be metabolic dysregulation, obesity, and end organ damage. And I would postulate, and I don't know, maybe you have demographic data, but just weight loss alone, if there's a lot of end organ damage, may not be sufficient. And Omar was nice enough to send me a paper yesterday where they looked at in animal models that even though they did bariatric surgery and then weight loss, even though the mice or rats lost weight, when they looked at the mitochondria, they still had abnormal energetics. So I think this concept that when you are in persistent inflammation or persistent metabolic dysregulation, it sets you up for epigenetic changes that may not reverse, even though the phenotype gets better. Just like the phenotype in heart failure, they get all better. But I think weight loss alone may not be sufficient, and diet alone may not be sufficient. And this then, I think, has public health policy implications for starting weight loss therapies earlier, and certainly on the issue of prevention. But I'd be happy to discuss this with people in the room after my talk. So again, I want to thank Guillermo and Tech Salud for giving me the opportunity to come here. It's been remarkable. You guys are doing phenomenal work. And Guillermo, I couldn't be prouder.
Hello. Thank you very much. Ahora tendremos oportunidad de preguntas. Por favor, si levantan la mano quien esté aquí. Y también les recomendaría, por favor, escribir las preguntas en el chat a la gente que está virtual. Por favor.
Douglas, thank you for your talk. It was very elegant, illuminating. I was wondering, so in this concept of improved heart failure, the definition was with ejection fraction less than 40, so we can think about HFrEF patients improving somehow 5, 10%. Do you think the same kind of concept could be tagged, for example, for HFpEF patients, 50% ejection fraction that may improve, I don't know, up to 55, 60?
Yeah, I think it's a really good and important question. I don't know what the answer is. I would postulate, based on what we know already, that there are probably a number of epigenetic changes. As you know, HFpEF, there's a lot of inflammation. And my guess is even though you treat the underlying causes, hypertension, obesity, that the heart still remains vulnerable to a second attack, whether it's tachycardia or a bout of hypertension or a bout of injury. The heart just loses resilience in this new steady state, and the likelihood that you develop heart failure is, I think, much greater. And as I said, I think there is a biological substrate for this that could be approach therapeutically. But I suspect the same ideas fit with heart failure with the preserved ejection fraction. The readouts may be different. The ejection fraction may never get better, but the strain, the diastolic filling may get better. There may be functional parameters that look better, but then remain vulnerable to a second insult.
Thank you.
Okay, thank you for the presentation. So my question is about the SGLT2 drugs. And the question is, do you think, given the mechanism of action of these drugs,
if you could tell me what the mechanism is, I'd be really grateful, because I'm clueless.
Well, the point about this is you have two options. One of them is through the kidney, and that facilitates the leak of glucose. The second one is whether that could be independent of the kidney effect. And I would like to know, based on this, whether you may have some insights about why this type of drug may improve.
First, I have to acknowledge that we don't really understand in the heart failure community why the drugs work. I totally agree with you that it's got to be renal. Why do I say that? Most of the other drugs that we give have an effect on mortality. There was only one of the SGLT2 studies that showed a very small mortality benefit. The largest signal is always on reduction of heart failure hospitalization. And it doesn't matter what the ejection fraction is, it reduces EF. So the one thing we know brings people into the hospital is congestion. And we know that the drugs do have some effects on tubuloglomerular feedback. There are complex renal interactions. I don't think it's all just diuresis from blocking glucose uptake in the tubules, but I think that there are complex renal mechanisms that we don't understand well that explain why these drugs are essentially miracle drugs for whatever form of heart failure there is. And so I think it has to be something to do with improvement in renal function. I just don't think we have the answers yet. The really vexing thing has been, the myocyte doesn't have any receptors for SGLT2. There's some evidence that it can bind to the sodium-calcium exchanger and work that way. But in the journal I edit, we see a ton of papers, but no one's convincingly ever shown that there are receptors that on the myocyte that work. There may be like a few tiny RNA particles, but I don't think there are meaningful SGLT2 receptors on cardiac myocytes. So again, just simplistically, the fact that it works in all heart failure, to me, means it has to have some important effects on the kidney. And I think that they're beyond just diuretic effects. Hopefully that answered your question.
Yes, and my second question is, do you think this homologic approach, proteomic approach, will be a good strategy to identify biomarkers predictive of the progression of the heart failure?
That's a harder question, because I don't know that so for established heart failure, there probably isn't a whole lot better than NT-proBNP. It's such a good marker for predicting progression. What we really need are people who are asymptomatic, the so-called stage A, that are at high risk for developing heart failure, and maybe start doing proteomic signatures there. The thing, as I said, I don't like about SomaLogic is it's not quantitative. They're relative levels. So as clinicians, we think of nanograms and picograms. And I know the Olink platform now they have a quantitative platform for 3,000 proteins, but SomaLogic's up to 11,000 proteins, all in a vial of blood this small. It's kind of mind-blowing. And it gives you a very broad picture of what's going on. So I think that type of approach ultimately has a lot of power. Whether it's going to be better than what we already have that just cost pennies, I can't tell you. I look at it as discovery platforms, right? It should inform you about changes that are important for symptoms, rather than as biomarkers to predict what can I learn new about heart failure that I didn't know before. It turns out a lot.
Hi, thank you. My question is regarding the inflammation, because I like to know if you have studied in a more profound the profile of inflammation that these patients have, because on ejection fraction, because we have two scenarios. On the one hand, we have that obesity that causes low grade of inflammation, doesn't alter the ejection fraction. But in the other hand, we have the patients that they show you that caused by inflammatory etiology doesn't recover like the other. So
Yeah,
what is the grade of inflammation of the role?
So we just published a paper in Nature Research. It's the new Nature journal, Nature Cardiovascular Research, where one of my other trainees, what they did was to look at single nuclear sequencing in failing hearts. These were people that we got from Stavros. So they were people who had heart failure, had an LVAD placed, then actually had the LVAD taken out, and then they actually were better, at least in the short term. The really simple take-home message is that there's a lot of inflammation, predominantly in the macrophage monocyte populations when you do single nuclear sequencing. And then the really cool part was the ones who got better all had the inflammation signature go down. So the amount of inflammation that was in the heart predicted who would recover and have the LVAD implanted, and those who didn't recover had a lot of inflammation. The ones who did, they went down, and Corey's gone on to develop, to identify specific transcriptional signatures within the leukocyte profile that may be driving the inflammation, and at least the early mouse data I've seen would support that. So I, along with Dr. Torrey, believe that inflammation is incredibly important. Just been really hard showing it in clinical trials for a variety of reasons. But I do think we now have information that recovery is linked to reduction in inflammation. But I can refer you to that paper if you want.
Thank you. We have time for 2 questions. Please.
Professor Mann, you showed that the postpartum myocardial disease had the better recover. Are there particular studies explaining the molecular mechanisms for that?
So there are 2 schools of thought. One of my late colleagues, Helmut Drexler, right before he passed away, they had shown that in heart failure there's splitting or with bromocryptine that parts of the molecule get cleaved, and that there's a toxic part of that molecule that drives the inflammatory response. So I think that there's probably some patients with postpartum cardiomyopathy that have that mechanism, and that has profound implications for whether a woman breastfeeds or doesn't, because if you breastfeed, you're stimulating that path, which could make it worse. And then Dennis McNamara has now got a clinical trial ongoing to test that. I think a large part of those are probably women with Titin mutations or low-grade genetic abnormalities that do fine because they're young, and then you have this massive volume overload, and the hearts do dilate, and they're carrying around a bag of water, and the extravascular volume expands, and so that they basically get stressed, and then they develop a LV dysfunction. But they recover, as I showed you from the genetic. They'll recover, and I think Cricket-Seidman has shown that a large portion of the dilated cardiomyopathies, the postpartums, do have Titin mutations. So I think, like anything, it's going to be heterogeneous, whether the bromocryptine hypothesis holds up, or whether these are all people with underlying substrate to develop heart failure, genetic substrate in particular, that then get stressed, then develop heart failure, but then recover. And then I think there's some obvious evidence for inflammation in that, and how that all ties in, I can't exactly tell you, but it's a fascinating group of people, and they clearly get better, and some of them never need to see a doctor again.
Thank you. Thank you, Professor.
Okay, another question? No? We have a general comment from Dr. Torre.
So, Doug, I'm going to take the opportunity to make 2 comments. So, no question.
Thank you.
I'll stand here because it's a... No, but it's a... so you have...
He never agrees with me. So.
No, I agree. We still continue to do inflammation trials, and they fail, but that's okay.
Join the club.
After 30 years. But so you have students from engineering, from medicine, from biology, and there's faculty and pre- and postgraduate course students. So I'd like to make two comments. One is that I guess everybody saw through the lecture the ability to combine multiple different sciences. So you saw clinical medicine, you saw data science, you saw biology, molecular genetics, and maybe machine learning, and at the end, a practical potential application for what we do in medicine. But everything was not about medicine. So I think the point that I want to make, because it's based, I'm using this as an opportunity to promote why we created the institutes like that. Why is it that bringing multiple different disciplines to try to answer a problem leads to a terrific results, or at least innovative results? So I think I wanted to highlight for everybody that that's what you saw in the lecture, independently of what inflammation may be, Elena, or Omar, what is it that we're going to do with changing obesity and these paradigms. So I think that is an important teaching point for everyone.
Yeah,
it was
no,
beautifully presented in the lecture.
Yeah, I didn't show it, but when we were first trying to develop the concept of recovery and remission, I went to the head of engineering, and I knew enough from my fellowship days about tissue properties. And so there's a thing known as elasticity and plasticity. And materials, just metal, if you stretch it, it's got some elasticity to it. And then if you stretch it too far, it stretches out, and the mechanical properties change, and that's called a plastic change. And I think that's a lot like the myocardium. When you lose myocytes, or the matrix gets degraded, or the heart's too dilated and the matrix is abnormal, that's a plastic change that never comes back to normal. So the first ideas that we had to try to formulate these ideas, I went right to an engineer, because that's what they do, right? They think about materials and things, and he helped me work through some of the concepts, and at least told me I wasn't too crazy. So I do think getting outside of your wheelhouse, if you will, your subspecialty, talking to other scientists, trying to find parallel stories, either in nature. My mentor, George Cooper, always used to say you had to put a fly in the paper. If you couldn't show it in Drosophila, then it wasn't real. But the idea was to look for other examples in nature of what you were seeing is correct. And I think certainly tissue engineering is a great example.
So then I'm going to go to my second point. And this will be more for those of you that are professors that are leading the research units or the directors of the units. And it's the following. So it sort of struck me when you put the first slide with me, I guess 20 plus years ago, and I had that psychedelic shirt. I don't know where that came from, but
he was always a snappy
But
dresser.
in that slide, so there is me, which I play a role here, whatever that is, but I don't even know what that is anymore. But it's me, and then there is another guy there that's called Samir Kapadia. Samir, just so that you know, is the chief of cardiology of the Cleveland Clinic, which is the #1 cardiology program in the world.
In the world, yeah.
I hate to say it because I always...
Second to Texalup right now.
Okay, so I envy that all through my career. But so that's Samir Kapadia, that's me. Rob McClellan, who's the chief of cardiology at the University of Washington. He mentioned Beacon Bosker, who is now VP of something at Baylor College of Medicine, and it's a very prominent woman in the field of heart failure and has a terrific career. Anita Deswell, who I remember, who's also very prominent in cardiology in the heart failure communities, in those writing committees. I also remember Hakan Oral, who did probably one of the most fundamental papers in treating atrial fibrillation with ablation many, many years ago. Luigi Adamo, who I met, who's now at Johns Hopkins leading heart failure research, and I don't know how many other people. I guess these are just the things that
Corey Levine is another one.
Okay, so these are just names that I remember.
Slava Eppelman is also up in Toronto, killing it.
So, and I did not do a research to look at that. I just was sitting here, just these names. So what is the point there? That one of the responsibility of those of you and I that have a teaching role is to create the environment for others to grow and be very successful, and to create a culture of research, which then, so that is my my comment, and it's a challenge to everybody here that's a professor and teacher, that is, it's not only about just writing a paper, right? So writing papers is great, we liked it, and I like them, and I like citations and all of this, but that is only a very small piece of it. I think the other major responsibility, if you are a professor at Tec de Monterrey, if you're a researcher, you have a research position, is to create the environment to make others grow and be better than you. Not that I'm better than him more than anybody.
He was so better than me 20 years ago.
so that's
no, I'm serious.
That wasn't the case, but I think that is really important. Yeah. So, and I mentioned that because I guess if I ever do something meaningful here, it's to create a new culture of research at Tec de Monterrey, which is all, these two were highlighted here, right? That's why I stood up and did it as a mini lecture at the end, which is the interdisciplinary approach, and then the cultural environment to look for research, and then to create the atmosphere for others to be very successful.
Yeah.
So thank you for that.
Thank you. I leave with one other word, is that a lot of young people get intimidated and daunted because they may fail. And as I said, in the early days, we had no idea what we were doing, and everyone told us we were doing the wrong thing by studying inflammation, and we just were unafraid to fail, and it was so much fun. And I think that's the thing, if you could just understand how exciting it is to do something that you don't know the answer, that even if people tell you what you're doing is wrong, if you still enjoy doing it, it's just enormously fun and rewarding, and then leads you in a linear way to the rest of your career of answering questions. But it was, it was a magical time. It really was.
Thank you. So you can come up here.
No, it's just a small comment. Also, when you put your first slide, I like it that you said we didn't have money, so we need to think.
So you're going to cut everyone's budget. No, so I think the ideas were so new that we couldn't get grants funded. I would go down to NASA, they launch all the rockets, and I would read echoes. They would have like 100 astronauts they were screening, and they paid me some ridiculous amount of money to go read those echoes, like $100,000. And so I would go down at 11 o'clock at night and read echoes till 2 or 3 o'clock in the morning, a couple nights a week. But we supported the lab with whatever we did. There was a time, I think I told Dr. Torrey this last night, when he always had more ideas than I could afford. And I told him, I said, if you come with one more idea that needs an expensive antibody, we're going to have plans to break into the Texas Commerce Bank because I can't afford it. Yeah, but it was, we really had a shoestring budget, but even despite that, we managed to get the studies done. And you can't waste money. You have to pick your experiments carefully. But actually, in some ways, it was more fun with no money because it was more exciting. Then when you have a lot of money, you can make a lot of mistakes, and it really doesn't matter. You can throw a lot of things at the wall and see what sticks. So, as I said, it was we really had no money.
Thank you very much. Again, Professor Mann, thank you very much for your wonderful talk. Thank you.
She's got 10 pictures to do.